Good evening, everyone. This is the fifth session of GLAD, the Gastroenterology Liver Academic Discussion Forum, where the primary objective is to bring the advanced gastro liver care to the primary physicians. And this has been going under the mentorship of Professor Subrat Acharya, and joined hand is Dr. B.D. Goswami, Professor Akash Shukla, and Professor A.C. Anand. And then we have made a vibrant team of editorial boards that is guided by Professor Y.K. Chawla. We have around 8 people who are dedicatedly doing the newsletters about each topics in a very lucid and crystal way for a general physician how to approach. So with this, we have covered very important topics like how to manage or diagnose approach towards jaundice, then ascites, and then bleed, and then we have covered the dyspepsia, GRD related things. And today is one of the most common topic, and say the core of liver, that is alcohol. And to discuss that, Professor Akash Shukla will be the speaker for this, and he has done a beautiful survey on that, what a doctor, what a common man wants to know, so that we'll get very much practical points in this topic. And along with this, we have panelist Dr. Chetan Ramesh Kalal. He is a senior consultant and lead at Nanavati Hospital, Mumbai. Dr. Pritam Nath, he is associate professor at KIMS, Bhubaneswar. And we have the core member groups with Dr. A.C. Anand has been not well, but he will be joining for the discussion part. And Professor Akash Shukla, Dr. B.D. Goswami. And now I'll request our mentor, who is the patron of this program, Professor Subrat Acharya, to give a brief introduction on alcohol and liver for a physician perspective. Sir, to you.
Thank you, Ashok, and welcome, friends. Very good evening. Well, the GLAD has chosen a very apt topic in today's day-to-day life, that approach to the liver diseases caused by alcohol. In fact, today, if you see patients with chronic liver disease, with liver failure, whom we call as decompensated cirrhotics, or we call, or sometimes we call them acute and chronic liver failures. You see, more than 60 to 70% in every hospital are because of alcoholic liver disease. Second, very striking thing which strikes you, the mean age will be around 40s. That is the most productive period of human life. A large bunch of patients or young fellows are coming with very severe degree of liver failure, threatening life. The third problem, besides the liver disease per se, the comorbid disease associated with alcohol, like obesity, diabetes, heart disease, kidney disease, or other ancillary troublemakers, making both quality and quantity of people a really painful experience in their sojourn of life. And thirdly, the social stigma and your family breakdown, road traffic accidents, menace to others. Having said that, we all know this. But if you see, the alcohol revenue is progressively rising. That means alcohol sale is progressively rising. And if you see the survey of age of onset of alcohol in India, particularly recent survey said it is around 15 to 20 years. So these are very disturbing elements of an intoxicant which is becoming very prevalent in the society, being started to be consumed at a very formative years of life, when right and wrong decisions are not very clear, unclear, forms a large chunk of patients with liver failure who have a high mortality. Problems of both social menace as well as family problems are associated with it. As expert, we discuss about the diseases, but I think we should always keep a public health aspect of diseases like this. They are vitally important. Whilst this is true, the research in alcoholic liver disease is also increasing rapidly. And the information about its various types of injury, its natural courses, their outcomes, the type of therapy has also changed or progressed further. Probably now we predict better, we treat better, we salvage better, and we select better for them to be subjected to liver transplant. So these various aspects we will discuss in simple ways. But most important message for physician in general is alcoholic liver disease is increasing. Anybody who is drinking roughly more than 3 drinks a week is at risk. Even though he doesn't clinically manifest, he should be screened for presence of underlying liver disease. It is important because in early stage, whole the liver disease process is reversible. And lastly, right, even if there are advanced diseases, it can be effectively treated and future liver-related dangerous complication can be prevented. Therefore, at the ground level, the knowledge on alcoholic liver disease is very important. That's not why I want to say so. If you want to add anything, go ahead.
In detail, I think Professor Akash, who is the speaker for the evening, has joined. So he will make his presentation. Then, sir, we'll have a discussion with our panelists, Dr. Pritam and Dr. Ram Chetan is there also. So now, with your permission, I will request Dr. Akash Shukla. Please unmute yourself, Dr. Akash.
Hi, Ashok. Good evening, sir.
Good evening.
Good evening, Akash. Welcome. We
Thank
are
you,
waiting for your lecture eagerly, as usual.
I'll just give me 1 minute. I'll just share my slides. Okay. So today, good evening, everybody. I'd like to thank Professor Acharya, Dr. Ashok Chaudhary, and Dr. Anand sir for once again having me here for this important session on alcoholic liver disease and alcoholic cirrhosis. So the first question which people very often ask me is, how do we know whether the alcohol that somebody is taking can cause liver damage? And for this, one needs to know how much is the actual alcohol consumption. So how do we really calculate this? So we need to understand how much the patient is drinking. So one small peg is 30 ml, one large peg is 60 ml, one quarter is 180 ml. Now, you should also know the volume of alcohol, that is the percentage of alcohol in each of these drinks. So beer would range from 4 to 10%. The non-fortified wine will be around 12%. Fortified wine, gin, so such drinks may be around 20%. The country liquor can vary, but by and large, it is in two approved strengths of 32.5% and 37.5%. And the hard drinks like whiskey would be approximately 40%. Now, this 40% is volume by volume. That means 100 ml of the drink would contain 40% of alcohol if the concentration is 40%. But the specific gravity of alcohol is 0.8. So if you look at the actual weight of alcohol consumed, then you have to multiply the volume by 0.8. So if somebody has taken 40 ml of alcohol, then the actual amount of alcohol consumed is 32 grams, because 40 multiplied by 0.8. The other way is to remember, one drink of alcohol is approximately 10 grams. What is one drink of alcohol? It is approximately one small peg of whiskey or one can of beer. So that is roughly what is equivalent to 10 grams of alcohol. So once we know that, then the second question comes, okay, how much alcohol consumption can cause damage to the liver? So even a single drink, that is 10 grams of alcohol, can cause fatty liver. But for cirrhosis to develop, the person has to take much more quantities and for a longer period of time. So if a male is drinking 40 to 60 grams of alcohol per day for more than 5 to 10 years, there's a 20% risk that this person will develop a liver disease, a major liver disease. Could be hepatitis or could be cirrhosis. For a female, this quantity becomes less than half. So even if a lady drinks 10 to 20 grams of alcohol per day for more than 5 years, she can develop liver disease. Why this difference? This difference is because women, they do not have gastric alcohol dehydrogenase, whereas men have gastric alcohol dehydrogenase. So the men will metabolize alcohol in the stomach to aldehyde form, which won't get absorbed, and that will cause around 5 to 10% of loss of the alcohol. Second, in women, because of their fat distribution, the alcohol gets sequestrated into the fat and gets resecreted, and therefore they sustain the levels for a longer period of time. And third, because of estrogen, they have a greater gut permeability and therefore increased injury because of toxins and dams and PAMs coming from the bowel because of increased gut permeability. So because of these reasons, women have a higher risk of alcohol-related injury. Then we have to know certain terms like harmful drinking, significant alcohol intake, heavy episodic drinking, or binge drinking. Of this, we need to know significant alcohol intake because that is what is associated with a high risk of injury to the liver. Then we should know any amount of alcohol that is consumed which can cause damage to health, either physical or mental, is called as harmful drinking. And binge drinking is consumption within 2 hours of 4 or more drinks for women and 5 or more drinks for men. And this pattern is associated with a greater risk of pancreatitis. Also, this pattern is associated with higher risk of acute alcoholic hepatitis. Then now we have DSM-5, which has come up with the term of alcohol use disorder. Now, this is extremely important for us to diagnose because very loosely we talk of term alcoholic. He is an alcoholic. And very often we do not believe the patient when he says, I drink once in a month. At times they say, this person drinks thrice a week, or I drink only 2 times a week. We do not believe them. We do not know what is the truth. So how do we know whether whatever he is saying is true or not? It is impossible to tell. Therefore, we have to depend on surrogate markers, where if the person has an alcohol use disorder, then he is likely to be drinking in a significant amount. And for this, these are the 11 criteria which are mentioned. It starts with as simple as criteria as alcohol taken in larger amounts or over a longer period than what was originally intended, persistent desire or unsuccessful efforts to cut down or control alcohol use, great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effect, craving or strong desire or urge to use alcohol, recurrent alcohol use resulting in failure to fulfill major roles of, at work, school, or home, continued alcohol use despite having persistent or recurrent social or interpersonal problems, important social, occupational, or recreational activities are given up or reduced because of the alcohol consumption. People stop going to parties, or people stop going with the family. They don't go to the temples. They give up on that. So all this comes in this criteria. Recurrent alcohol use in situations in which it is physically hazardous, like while driving a car, or for pilots, for example. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. Tolerance, which is basically uh, markedly increased amounts of alcohol needed to achieve intoxication or desired effects, or markedly diminished effect with continued use of the same amount of alcohol. And the last criteria is withdrawal on stopping alcohol or taking alcohol to relieve the withdrawal. And then, of course, you classify them into mild, moderate, and severe based on the number of symptoms. Up to 3 is mild, 4 to 5 symptoms is moderate, and more than equal to 6 is severe. And then you have these certain tools. So if you can't remember the 11 criteria, you remember the first 3 criteria of this audit. That is, how often do you have to have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you're drinking? And how often do you have 5 or more drinks on one occasion? If the answer to the top 3 is at least 1, then you know that this person is having a alcohol use disorder. So don't remember all the questions. Don't remember the DSM. At least remember these 3 questions. For those who can't even remember that, CAGE questionnaire is something very useful. 4 questions, CAGE. C stands for have you ever felt you should cut down on your drinking? A is have people annoyed you by criticizing your drinking? G is have you ever felt bad or guilty about your drinking? And E is did you ever require an eye opener, that is alcohol first thing in the morning to steady the nerves or get rid of a hangover? Even if one of these is positive, then this person is very likely to have an alcohol use disorder. So something as simple as this can be used in the routine OPD, and I would recommend everybody to identify whether the quantity of alcohol consumption is pathological or not, whether the person has alcohol use disorder or not. So use this freely. Don't rely too much on the history given by the patient or the relatives. In fact, there's a study which has shown that the family members actually underreport the consumption of alcohol much more than the patient himself. So the family members are not there usually when the patient is drinking, and therefore they would almost always underreport much more than the patient himself. Now, this is a very important chart which all of us should know. Of 100 people who drink heavily, like what we discussed, significant quantity, almost 90% will develop fatty liver. Of those who develop fatty liver, around 20 to 40% would have a progressive disease. Half of them would develop alcoholic hepatitis. The other half would develop progressive fibrosis. Around 8 to 20% of these would develop cirrhosis. Of those who have alcoholic hepatitis, almost 70% would progress to cirrhosis. And those patients who have cirrhosis, almost 40% would have severe alcoholic hepatitis if they continue to drink. And 3 to 10% of patients who have cirrhosis would develop hepatocellular carcinoma during their lifetime. Now, who are the ones who are more likely to progress? Female sex, drinking pattern, especially those who are having binges, they are at higher risk of alcoholic hepatitis. Quantity consumed, greater the quantity, more is the risk. Obese people are at higher risk with the same amount of alcohol. Co-infection with hepatitis B or hepatitis C, and presence of certain genetics. And these are also the reasons why some people who, despite drinking heavily, do not develop liver disease. So many of them are genetically blessed. And therefore, when a patient comes to us and he says, my friends drink much more than I do, they do not have a liver disease, why did I get a liver disease? The answer is simple. It could be any one of these factors, but the most likely factor is genetics. So somebody may not be genetically predisposed to alcohol-related injury, and that's why he's not developed alcoholic cirrhosis or alcoholic hepatitis. So let's start with the case. Here is a 43-year-old gentleman who has been consuming alcohol around 180 ml, that is 1/4 of whiskey per day for last 5 years, is asymptomatic. On routine health checkup, he's found to have a bilirubin of 2.4, SGOT of 123, SGPT of 145, normal albumin, alkaline phosphatase mildly elevated, and platelets of 4.2 lakhs, which is again normal. INR is 1.1, and ultrasound shows a fatty liver. So this patient has alcoholic hepatitis. The bilirubin is slightly high. The SGOT, SGPT is increased. All of the viral markers are negative. That is the first thing that we will do in this patient. The next question comes, how do we prognosticate that this patient has severe disease or mild disease? So the first question here is whether our patient has cirrhosis or he has just hepatitis. So this patient is unlikely to have cirrhosis because the platelet count is really good, 4.2 lakhs. Of course, there are no other features of cirrhosis radiologically. Also, the duration of alcohol consumption is still not long enough for him to be at very high risk for development of cirrhosis. So, assuming that this patient has alcoholic hepatitis, we need to find out whether this patient has severe alcoholic hepatitis or mild alcoholic hepatitis. If it is mild, the chances of mortality are extremely low if the patient stops alcohol. But if the patient has severe alcoholic hepatitis, the risk of mortality becomes high. So how do we do that? We do something called as DF, or discriminant fraction, also called as Medrey's index, which is nothing but 4.6 multiplied by the difference in the PT, prothrombin time, test and control. So here it will be 14 seconds and 13 seconds. So it's 1. So 4.6 into 1, that is 4.6, plus total bilirubin, which is 2.4. So here it comes to 7. Anything less than 32 is mild. Anything greater than equal to 32 is considered as severe. So our patient has got mild alcoholic hepatitis. So the next question comes, and I'd like to ask Dr. Ashok, what would you advise this patient for mild alcoholic hepatitis? Would you advise silymarin, metadoxin, S-adenosylmethionine, UDCA, pentoxifylline, all of the above, or none of the above?
Frankly speaking, there's two components. One is patient satisfaction and is science. If you go by the science for this mild, it is a nutrition and stopping his alcohol, bit of multivitamin is going to help. But when a person comes, because we are general physicians or a gastroenterologist, इतने बड़े डॉक्टर देखा है, दवाई कुछ नहीं देखा. So then you have to think of something to give. Otherwise, for all patients, I should say that treatment is always the nutrition. That is the most cornerstone for the alcoholic hepatitis.
Absolutely. I completely agree with Dr. Ashok. So this patient actually does not require any specific drug, and therefore none of these drugs are really indicated for the benefit of the patient. You may use them because the patient needs a drug, but none of these are really required. What the patient needs is liberal nutritional supplementation. So these are the patients where you should give multivitamins, especially thiamine, where the patient is likely to be deficient. So fat-soluble vitamins, water-soluble vitamins, calories, proteins, all these are extremely important. So that becomes the backbone of therapy. Plus, you have to also ensure that these patients stay away from alcohol. So they are abstinent. So you will need to give them pharmacotherapy to stay away from alcohol while they're recovering from alcoholic hepatitis. The other thing which you have to keep in mind is one-time reading may be low, but a small subgroup of these patients can progress to severe even if they're not drinking. So always repeat an LFT after 1 to 2 weeks, even if you have diagnosed mild alcoholic hepatitis, to ensure that the bilirubin is not increasing, the PTNR is not getting deranged. So always repeat after 1 to 2 weeks. If it is falling, then we are good. If it is increasing, then you have to keep a very close watch and keep on repeating the LFT and INR probably every 1 to 2 weeks. Now, there are multiple mechanisms by which alcohol causes damage, but the most important is the oxidative stress. And that is why most of these drugs which you mentioned, they work on the oxidative stress, they are antioxidants, and therefore they're presumed to have some benefit. However, they are all very poor quality of evidence, and therefore none of them are routinely recommended for management of these patients. So this is what the evidence says. For Silimarin, if you see, there are certain studies which have shown some benefit. Same way with curcumin, some improvement in SGOT, SGPT, some improvement in liver pathology. Same way with LIV52, some improvement in TNF alpha. So none of these really change the outcome. They may modify and have some benefit on some reports. Same way with pentoxifylline and acetylmethylmethylene. So some improvement in certain parameters, but no hard endpoints are achieved. So like Dr. Ashok Chaudhary said, the cornerstone of treatment is abstinence and nutrition. So how do we administer nutrition to these patients? The principle is the patient should take 7 meals per day, including a late night snack. For everybody, for prevention of GRD, last time we have heard Dr. Anand speak that you should not take food after dinner. After dinner, you should take at least a 2-hour gap before you go to sleep. This rule is not applicable to patients with liver diseases, especially those with cirrhosis or alcoholic hepatitis. They must take a late night snack just before they go to sleep. Ideally, for recovery, they require 35 kilocalories per kg per day of ideal body weight. Do not include the ascites, do not include the current weight. Whatever is their ideal body weight according to their height, 35 kilocalories per kg per day, and 1 to 1.2 grams of protein per kg per day of the ideal body weight. So those whose intake is more than 50% but less than 80%, we must use nutritional supplements. And if it is persistently less than 50% of the requirement, despite all the counseling, then you would opt for a nasogastric tube. Liberal supplementation of vitamins and minerals like thiamine, magnesium, and selenium. Please do not stop fat or oils or ghee for these patients. They must take in small quantities. Remember, for liver regeneration, the cells have to form. When new cells form, they require cell material and they require a cell membrane. And every cell membrane is phospholipids. That is, it has phosphorus and it has lipids. Also, it requires a lot of magnesium and energy, ATP, for the liver to grow back. Therefore, we have to supplement food which is rich in magnesium, which is rich in calories, and it should contain some amount of fats. So please keep this in mind and ensure that your patients have these things in moderation. The next question comes, if a patient has liver disease, how can we treat their alcohol abuse? So you have three drugs which are US FDA approved: acamprosate, disulfiram, and naltrexone. So of this, acamprosate doesn't have a hepatic metabolism and therefore can be used safely in patients without advanced liver disease. So compensated cirrhosis or mild alcoholic hepatitis, we can use acamprosate as a drug to help remain abstinent. It is more useful for maintaining abstinence. Disulfiram, we are all aware, it is acetaldehyde dehydrogenase inhibitor, and if the patient takes disulfiram and drinks alcohol, he gets severe nausea, vomiting, uneasy feeling, tachycardia, perspiration, redness of face. He feels very ill. The problem is this can by itself cause liver injury, and therefore it is best avoided in patients with liver diseases. So disulfiram is a good drug in those without a liver problem. In the presence of liver problem, disulfiram should be avoided. Next is naltrexone. Again, something which is very useful in people without liver disease, but again, in the presence of liver disease, you cannot use naltrexone. So the non-FDA approved drugs which we often use are baclofen. It is a GABA B receptor agonist, minimal hepatic metabolism, and it has been studied in patients with cirrhosis. So in child A, safely, and in child B, selectively, we can use baclofen. The only risk is in some patients, it will cause sedation and therefore can precipitate hepatic encephalopathy, especially in those with advanced cirrhosis. So baclofen is today my drug of choice in inducing abstinence from alcohol. Acamprosate works well for maintenance, but for induction, baclofen works better. The other option will be gabapentin. But again, the risk of encephalopathy is there because it does have sedative effect. Topiramate and varenicline are again good drugs. Unfortunately, varenicline is still not available in India, and therefore we don't have access to it. Topiramate has a hepatic metabolism, and therefore we cannot use it in patients with significant liver disease. So practically, in presence of liver disease, we are left with only three choices. For those without any significant liver, with mild alcoholic hepatitis or child A cirrhosis, for maintenance of remission, you can use acamprosate. For those patients who are having active alcohol consumption, you want to induce abstinence from alcohol, there you have the option of baclofen and gabapentin. Now we are all aware that we give steroids for patients with severe alcoholic hepatitis, those who have got a DF of more than equal to 32. So should we do a liver biopsy before giving steroids to this patient? And here my answer is, contrary to the belief that it is not necessary, it is actually necessary, because in up to 30% of the patients, what we think clinically is alcoholic hepatitis on biopsy is not alcoholic hepatitis. And therefore, I would recommend that in the peripheries, please do not try to give empirical steroids to patients with severe alcoholic hepatitis. I'll discuss the contraindications to using steroids in one of my later slides. But remember, we give steroids only after doing a liver biopsy, because in 30% of the cases, the diagnosis changes. And if there is no alcoholic hepatitis and you give steroid to these patients, you can actually kill the patient. So this dilemma is because biopsy is alcoholic steatohepatitis, which is characterized by certain features like steatosis, ballooning degeneration, apoptotic bodies, and presence of polymorphonuclear infiltration, along with Maillard bodies and cholestasis. Whereas the clinical syndrome that we identify is acute alcoholic hepatitis. So, therefore, this difference between clinical alcoholic hepatitis and alcoholic steatohepatitis on biopsy, the mismatch can be seen in up to 30%. The next question comes, if the patient has infection, can we give this patient steroids? The answer is no. In the presence of infection, do not give steroids. So it is mandatory, before we start steroids, we should ensure that the patient doesn't have any infection. Very often we'll be confused because the WBC count is high. And therefore, we cannot rely upon counts alone to say whether the patient has alcoholic hepatitis related elevated counts or it is infection related elevated counts. And therefore, we would rely on cultures, on imaging. So typically we would do an X-ray chest, if required HRCT thorax, ultrasound of the abdomen, cultures from the urine and blood cultures. All these should be negative. Only then we would consider giving steroids. Can we treat the infection and then give steroids? So in expert centers, yes, we can do that. This study showed that we can actually treat the infection and then we can give steroids as long as we are sure that we have cleared the infection completely. So, sorry, I think I missed a slide. So when you have a patient who has got a definite alcoholic hepatitis, you see whether there are contraindications for corticosteroids or not. If there are contraindications to corticosteroids, then we treat those contraindications. What are those? Presence of any bleeding, presence of any infection, presence of renal insufficiency, severe malnutrition. So if any of these are present, then if you can treat and reverse them, then you can use corticosteroids. Then you see whether there's a drop in bilirubin at 7 days or not. So first at 4 days and then at 7 days, you should have a significant drop in bilirubin of at least 2 points. You can also calculate something called as Lille score, which I'll come to a bit later. So if the Lille score is less than 0.45, then we can continue. Otherwise, this patient is unlikely to respond to steroids, and therefore you need to put these patients on, if possible, for transplant, or you can look for other experimental therapies. So then we come to the next big question. What should we do for those who cannot be considered for steroids or who do not respond to steroids? And like I said, the best option for these patients is transplant. So these patients will do very well with transplant. The problem is, again, it is out of reach for most of the patients. So if you look at this study, very well done study, out of 430 patients with severe alcoholic hepatitis, only 132 were eligible to receive steroids. Out of these 132, 99 patients responded. 331, that is 77% of patients, were either steroid ineligible or non-responder. And only 1 to 2% of patients of these actually undergo liver transplant. So majority of the patients actually do not have the option of transplant. So for these patients, good supportive medical care, nutritional supplementation, and abstinence from alcohol is the only way forward. And that is what we have to emphasize to our patients. Stay away from alcohol, good nutrition, liberal supplementation, and good supportive medical care. That is all that is required for most of these patients. The drugs which we use, most of them do not change the outcomes. It is these parameters which are going to change the outcomes. And here I would want to spend certain time on understanding the psyche of the patient who has got alcoholic use disorder. Very often you will find that these patients are sick. At that time, they realize that they have to give up alcohol. They will give up alcohol. And after 6 months, then when they're fine, they will invariably go back to alcohol consumption. So what do we do for such situations? Can we do something? The first thing is understanding and explaining the same to the patient and the family. Alcoholism is also a disease, just like any other disease. Just like any other disease, alcoholism also has its own natural history. This natural history is of relapses and remission. The moment the patient is fine, feels normal, at some point of time, he will get the craving back. It is the nature of the disease. Once the patient gets the craving back, at times, even with the best willpower, he will not be able to control and will go back to drinking. We should not be judgmental on these patients because they've gone back to alcohol consumption, because that is the natural history of the disease. This is something which we have to understand, and we have to make the family understand that do not judge if he's got a craving again or if he started drinking again. What we need to be sure of is explain the family that they should always have an open channel of communication with the patient, so that whenever the patient gets a craving to have alcohol, he should be able to come and confide with the family or the support system that is in place, so that there is a good chance that with the support system, the family, the friends, the ecosystem helps him stay away from alcohol. So rather than conflicting or blaming the patient कि तुम इतना भी कंट्रोल नहीं कर सकते, इतना सब होने के बाद वापस ड्रिंक कर रहे हो, instead of saying this statement, they have to understand that this is what is expected and therefore be prepared for it, and whenever it happens, they act immediately. So I think this is the mindset which we have to ensure, and that is what will help a lot of our patients and prevent recidivism in these patients. So most of our patients require a better standard of care. Unfortunately, none of this such drug exists. There are a lot of drugs which have been tried, which have been failed, a lot of drugs which are being studied, but they have not really worked. What works is to some extent N-acetylcysteine in patients with acute alcoholic hepatitis, but none of the other regenerative agents, anti-inflammatory agents, they have worked. There's some data coming up with fecal microbiota transplant, with rifaximin, with bovine colostrum, with liberal supplementation of zinc, but all these are experimental. And therefore, as of now, none of this can be recommended. Similarly, role of GCSF. A lot of people used GCSF. This paper showed that there could be some benefit, but again, not replicated in other centers, in individual experiences. And now we have a negative European trial to say that GCSF may not be the best treatment. And therefore, despite the initial enthusiasm, we are still waiting for more robust data before we use GSF. And therefore, most of these patients would go into either in major centers into therapeutic trials, but in common man's practice, if the patient is not eligible for steroids, if not responding to steroids, then we must emphasize on abstinence from alcohol, nutrition, and other support systems. So my 10 take-home clinical points. We must discriminant fraction to classify patients with alcoholic hepatitis as severe alcoholic hepatitis or mild. For mild alcoholic hepatitis, nutrition and abstinence is sufficient. We do not require any other modality for therapy. The biopsy is necessary to diagnose severe alcoholic hepatitis, and do not empirically start these patients. Those who have got severe alcoholic hepatitis, we must use steroids with or without N-acetylcysteine, and it may be used in some cases after you have controlled the infections. But again, this is best left to expert centers and should not be done in routine practice where these facilities are not available, especially because steroids can kill these patients. Other thing is to remember that steroids benefit only in the short term, and that too, a very small minority of patients. So it is not that it is going to help everybody. It only reduces 28-day mortality. The long-term mortality is only because of abstinence from alcohol and nutritional supplementation. You have to use the Lille score for response to steroids on day 4 and day 7. And although liver transplant is the standard of choice for steroid non-responders and ineligible, but you need to be very careful about choosing these patients. And also it is out of reach for majority, those of course who can afford and who have a donor and the support system, no major psychiatric illness, they can go for transplant. But for others, it remains abstinence from alcohol. There are many emerging therapies, but we still do not have a better alternative. FMT is something which is emerging as a promising, cheap and safe, but again, there is very limited data, and therefore it is quite challenging as of now to offer these to our patients. So thank you very much, and I'll now raise a few questions with my panelists. So I would like to ask Acharya sir. Sir, what is your practical tip to ensure abstinence from alcohol in those patients who have a significant liver disease?
So there is no practical tips. Nowhere, no experiment has succeeded, except one thing, which is definitely has succeeded, that is the social or family responsibility. Abstinence is only feasible and only successful in those persons who has a family to support. Support for abstinence specifically. Without that, it's a hypothetical possible steps to withdraw alcohol ingestion. But well, practically, you also know the data, 84% patients do not or fail to succeed in abstinence. 16% patients only succeed. So that's the reason. So you need a family support. So my tip is I search for a family. And second tip to them is those who has a liver disease, you have to use a little psychotherapy, psychomanipulation. I will not go into the details of psychomanipulation, but psychomanipulation of an individual patient is vitally important, which you do directly or indirectly, but we don't realize very time. I call it specific psychomanipulation. Third thing is persuading them to come for repeated follow-ups. Nobody important. If you meet them much more frequently, it is the rate of success might be much more higher. So these are very simple technique in certain patients, particularly if you see a younger generation group of people who need more attention. You meet them very frequently, and that works. That will be my answer. I don't have many magic answer.
Right, sir. Thank you so much, sir. I would agree. I think we have Professor Anand, Dr. Preetam Nath, and Dr. Chetan Kalal. I can see these names. So I would
Akash also, Dr. Akash. Dr. Akash also
Dr.
joined.
Akash is also there. Great. So I think we have good panel. So I would start with Dr. Chetan. How do you ensure nutrition? Because most of these patients are very poor, have very poor intake. So how do you ensure that they contain they take?
I think Dr. Chetan has a double connection, getting echo. I think so in the meantime, Akash can take this, Dr. Akash.
Akash.
Hello, sir. Hello, everyone. I'll not be able to switch on my video.
Yeah.
Okay. Pertaining to nutrition, I think it's a central part of management of any
No, I
patient with
think it's
alcohol
Dr.
consumption.
Akash. You are not clear.
I think Chetan, I think your voice is there is a problem with your audio. So Akash, you can take up now. You can speak now.
Is it audible, sir?
Yeah.
Yeah.
Yes, sir. So nutrition is generally the central core point of any patients with alcohol-related liver disease or alcoholic hepatitis per se. The management, what we generally, the targeted nutritional therapies that we have, which is recommended for patients with alcoholic hepatitis, it again ranges from the protein recommendations of about 1.2 to 1.5, and again 35 to 40 kilocalories per kg body weight per day. The challenges is people who are present with severe alcoholic hepatitis, the overall intake capacity. We do recommend these, but to ensure that we reach these targets is sometimes very difficult. Mostly what we find that we fall short of our target goals. There have been some studies which have advocated an early use of enteral nutrition in people who do not meet these criteria. But again, that itself comes with its own challenges in the management. One thing which I think we were recently discussing this, there occurs a change in the nutritional intake in people who we start on steroids. We all have seen that steroids possibly have, and we know this also, that steroids do have a mood elevation, increased appetite, these features that are there. This is just a personal observation which I've seen. Those patients who we initiate on steroids generally their nutritional intake also tends to increase. I don't know whether others share the same thing or it just
steroids do increase the appetite. They do increase the sense of well-being, and therefore, actually, even if they do not improve the liver function, the patient's general sense of well-being does improve in a significant number. So I completely agree with you, and I agree with you that it's a big challenge. My question is, we all know that nutrition is extremely important, and most of these patients have poor appetite, especially those with child B, child C cirrhosis, severe alcoholic hepatitis. They're very poor intake, and therefore we need a nasogastric tube. So, Ashok, how do you convince your patients to have a nasogastric tube? That's a practical challenge.
Yes. So before that, I just want to add to the Akash and your question. What happens when a person comes to you with jaundice because of alcoholic hepatitis? It is they are totally nutrition have jaundice, not to take yellow things, not to take turmeric or haldi, and has to take boiled food. And this is not the layman's prescription. That is also mostly doctors also doing. They are telling just you take only boiled, simple, sadha khana hai. So I request through this that it is. I think, sir, you can agree. Alcoholic hepatitis, no restriction on any food. I think say, or you can add anything. That is one. Second, people think that oil will be bad. In fact, we are doing research by adding ghee and butter to give them more calorie. So here the physicians should go with a note that they have to give enough of milk, whatever they want to give. There is no restriction. Oil wise no restriction, ghee wise no restriction. So that will make taste. The patient before coming has fed up with his food. So that's it. They lost the interest for the food. That is the first thing you have to ensure. The diet, you can take what you are taking before. If you have swelling, you have a tummy is out, if a doctor is telling that you have ascites or pellaedema, then restrict only on the salt. If you not on the sweets, not on the oils or anything, that is a fast. So that if he get a quality food as per his taste desire, he can take the food. So that is the first thing you have to ensure, that everything can be allowed to you except a little bit of salt restriction maybe. One. Then second, for the Ryle's tube, when a patient is conscious, comfort, and it is moving around, is difficult to do. It is only thing that we have to tell him repeatedly, this is the treatment, this is the nutrition, this is the only therapy. Then most important here comes our dietitian who is the calorie recovery. We have to tell that you see you are 70 kilo person, if you need 35 calories per kg, then it is coming to 3000 or 2500 calories. And we have done a calculation for you yesterday, what you have taken. It is coming already 700, 800. That means you are taking 1/5 of your diet, what is desired. So I think in 1 or 2 days with 4 to 5 times counseling, first to the patient and second is to the relatives, because relatives also another head block when you think of giving a tube. And third is what we have done our practical experience, a nurse guide. We have done a small video on that. So everything you can do also, whoever doctor, physician is there, they can do in their clinic. That this is a simple procedure that safely goes without pain, and you can take a bite or a video that is called educational video, that देखो इस पेशेंट से हमने कराया था, उसकी वॉइस लो कि नहीं मैंने डाला था, मेरे को कोई नहीं हुआ था. If we can ensure both to the relatives, to the patient, as well as we can get a feedback from a patient who has taken Ralsto before, I think all these three things, if you can combine, and we may achieve some success in putting a nasogastric tube to ensure diet.
So Dr. Chetan has put in a comment, no matter what you do, that is very difficult to convince a patient for IELTS tube. So I agree with you, Chetan, it's difficult. That's why we brought this up. But I think these are useful tips. And this is what I emphasize in my talk also, that do not restrict oil, do not restrict ghee, do not restrict, because it is important. Phospholipids, which is a part of the cell membrane, is lipids plus phosphorus, and therefore they have to be given to the patients. And very often when you find that people losing their muscle mass, people becoming just skin and bones, the muscle mass is completely gone, the cheeks are sunk, within 4 weeks, 6 weeks of jaundice, it is not because of the jaundice, it is because of the dietary restrictions. And therefore, except for salt restriction in those with ascites, I don't think we need to restrict anything for these patients. I think that is what, believe me, in the first 10 years of my practice, it ensured that a lot of patients stopped coming to me because they thought that I was crazy and they went to other doctors. But last 5 years, this has actually helped me increase my practice because they are happy when they come to me because they get to eat. So I think that is what needs to be done. We have to ensure that patients take their meals well. Ashok has given some useful tips how you can convince them. I think each one will have to probably use something or the other on similar lines to ensure that we do what we can. Next question I would want.
Sir, another more thing, sir. Sir, just to add in that, non-veg should not be restricted. That is also another thing. That it is non-veg a good source of protein. So most people think that jaundice we should avoid non-veg. That is not true.
Yeah. Similarly for patients, so there are certain things. I think since we have talked about this, another very important habit or culture which I've seen, or trend is which I've seen, is the moment anybody gets jaundice, he's given a lot of sugarcane juice. 3 glasses, 4 glasses of sugarcane juice in a day, other lot of fruit juices. Dr. Preetham, would you want to comment on this? And is it good for the patients or bad for the patients, such large amount of fructose?
Hello, good evening. We do not actually advise fructose. Actually, what will happen is taking this quite amount of sucrose can cause early satiety, and patient may not be able to take adequate proteins. And the solution is not giving excess sugar. Actually, the patients will not be able to take full meals. So we have to enrich it by increase the amount of calorie by adding oils, because they are calorie dense, very calorie dense. It will contain twice as amount of calorie like as compared to carbohydrates. So, like you said, sir, 6 meals, we tell 3 meals, and it should be spent with 3 snacks and 1 nighttime snacks, and there should be no restriction of oil. And as Ashok sir said, this food has lots of doctors also. I have seen also some dietitians, they are telling that, sir, this patient is having alcoholic hepatitis. Shouldn't you be advising hepatitis diet? There is a different hepatitis diet when the patient will get only boiled things and all. So, and lots of sugar. Apart from this sugarcane juice, some patients are also advised to take a huge amount of glucose also in patients, also for alcoholic hepatitis, and also in patients with acute viral hepatitis. So I think this should not be done.
Perfect, perfect. I can't agree more with you, Dr. Preetham. So fructose, such large quantities, sugar and fructose can actually be harmful because you can actually get fructose toxicity. It itself can precipitate acute fatty liver and make the liver conditions worse. And therefore, we should not be overdoing it. Yes, we know that the glycogen reserves are depleted in patients with severe alcoholic hepatitis or severe hepatitis. Therefore, you require simple carbohydrates to some extent, but an overdose is never needed. So a regular meals like what we discussed, 7 meals a day, 7 feeds a day, 3 meals and 4 snacks, including a late night snack, would cover almost everything. And therefore, do not be very harsh or restrictive in terms of meals, especially fats and oils. And do not ask them to drink excessive amount of juices or sugarcane juice, because that can also cause more damage than benefit.
Sir, if I could add one thing, sir.
Yeah, please, Akash.
We get to see a lot of patients who get referred who have been loaded with isotonic as well as dextrose and normal saline, and they just, it's a practice that anybody who has got alcoholic hepatitis or any viral hepatitis is just keep on loading them with IV fluids. It does nothing but to just increases the third space, and they end up in worsening of the ascites. So I think this is one more practice which should change, that any patient with alcoholic hepatitis which is seen outside, don't just keep on loading them with B5 and DNS, and they're getting 3 to 3.5 liters of fluid every day, which does nothing but to worsen the ascites possible.
Yeah, I completely agree with you, Akash, there. I think that's a very valid point which he has brought up, is how much fluids do we give to our patients when they come with alcoholic hepatitis. As far as possible, we want to avoid giving parenteral fluids if you can give enterally, whatever is required. But if at all you have to give parenterally, then we would want to avoid hypotonic fluids, like Akash mentioned. So don't use 5% dextrose, even if the patient is volume depleted, because it is not going to replenish the volume. So you can, if you want to only give calories, then you can use something like 25% dextrose or 50% dextrose. That will give some calories if you're not able to meet orally for whatever reasons. But do not load them with excessive amounts of fluids, 3 liters, 4 liters. That is almost never required. So I think very valid point. Thank you, Akash, for bringing that up. I think we still have time for a couple of more questions. I would want to ask Ashok.
Sir, one more question to you, sir. It come in the chat box. What is the role of propyl thiouracil for alcoholic hepatitis?
So again, there was initially some data which was there, which had shown, but then subsequent negative trials are there, and therefore today we do not use propyl thiouracil.
Yes, sir. Continue, please.
Yeah, so we have spoken today more about alcoholic hepatitis and not talked much about chronic alcoholic cirrhosis, because I thought alcoholic hepatitis was something which was more burning question, which we face much more often, and the discussion would be far too much if we include both cirrhosis and hepatitis. So Ashok, your practical experience when you see patients with severe alcoholic hepatitis who are not responsive to steroids, or who are ineligible for steroids, because that is almost 75% of our patients. So you were in an institute where you were using different protocols on them. Now, when you're out of that institute and you're not having any protocols for them, what is it that you use for them? I want to ask you, and then the same question I would want to ask Acharya sir and Akash and Dr. Preetham.
Yeah. So basically, first of all, I need to assess the patient first of all about the recidivism in the form of his history, family background, profession wise, likely to go for one. And as per the literature, that when there is non-response to steroid or they're not eligible for the steroid, it is only way out is the transplant. And so before transplant, particularly in Indian scenario, we have to think of all the social part, donor, finance, and everything. If it is there, definitely I will go for that. Second, when there is no transplant options, we think of having a plasmapheresis. or plasma exchange. And here we got a limited results, but that is only done as a bridging therapy, or you can say that is only one of the therapy which is available to give. That is second. Then third, because we have little bit of practical experience on this GCSF, so sometimes we use the GCSF along with nutrition, because steroid we cannot give, but we are not able to find any results with that. So this is only three things. And four important thing that sometimes we get some clues: young age, no varices, no ascites, platelets is on the normal side, so or on the hair side. So these are the very short points where you can think these people may cross over a period of alcoholic hepatitis only nutrition therapy. They may come up also. So there is one conservative approach, two is the transplant, that is definite approach, and third is you have to go for whatever is available with you, like plasma exchange, GCSF. These two we think of, we are thinking of. FMD I am not able to give. So these are the two things we sometimes think that can be done.
Acharya sir, what do you do for your patients who cannot take steroids, or whom you think are not the candidates for steroids?
You are asking a group of patients who have very severe alcoholic hepatitis or acute and chronic liver failure. They may have organ failure, but they may not have organ failure. If they have organ failure, that's a different story altogether. They don't have organ failure and they have simple alcoholic hepatitis or ACLF 0, whatever you may call. Obviously, step one is to start steroid if there are no infection, which you all people do. Now, if there is no early change in bilirubin level, which is predominant determinants of Lilly score, right? Besides the age, albumin and INR and creatinine, the prognosis obviously is grave because there is no regenerative capacity despite the inflammation being obtunded by steroid. That's simple indication. Then next question is all right, transplant is indicated, but most of your patients do not get transplant, and Akash problems lies here. Also Ashok's problem, also my problem. We don't have anything magic here. We have lectures to give. We have prognostic model to speak here. This happens prognosis, this happens this. We say this may be what period, whatever it period. We may say this is a therapy you can try, GCSF or say Plex or say all the experimental therapy. But remember, none of them are hunky-dory therapy. None of them are foolproof. And they are discussed with doubts and questions. So obviously that simply indicates a clinician when discusses a treatment with doubts for information, not for recommendation, there is a question of such therapy. So there is no therapy. And that is the junction, which is the question of Akash. What do you do? Well, Akash, you realize I have given you the answer. There is no clear-cut answer. What I do, if you ask me, is purely different thing. I maintain their albumin level more than 3.8. I maintain their renal perfusion, right, irrespective of their creatinine status with terlipressin. I decrease their systemic vascular resistance. I increase their nutritional intake, which I monitor day by day. Say more than at least simple 2,300 calories per day, kilocalories. Fourth, I will ask them to prevent respiratory tract infection by blowing. That's what I do. You ask me what I do. I do this, right? And I buy time in patients with alcoholic liver disease. Of course, I replenish them all other nutrients and correct the electrolytes, maintain the remaining things. This is what I do in this select group. If they cannot have transplant.
Yes, sir. I can't agree more, sir. I think that is the beauty. Majority of these livers can still probably regenerate if we give them long enough time and we give them the raw material to regenerate. So
I simply make them dry and make their albumin good.
yeah, so we prevent the complications to whatever extent possible. That is what Dr. Acharya sir is trying to do by maintaining the albumin levels more than 3.8 or 4. Because then you keep them dry, so you reduce the risk of SBP, and finally you're giving them the raw material to the liver, which hopefully it will process and attempt to regenerate. So I think that is the beauty of what Professor Acharya sir is talking about. We all do it knowingly or unknowingly. I think that, but those are the principles, that you give proper nutrition, ensure abstinence from alcohol, no added insult to the liver, and minimize the complications to whatever extent, and hope that the liver starts regenerating over a period of time. And I'm sure, sir, you will have, I probably have few hundred, you will have a few thousands of cases where
I know.
the patients have survived despite all the scores showing that this patient is not going to survive.
They survive. Many of them survive.
Yes. So I think there's one more question which has come. Does HCV infection in alcoholics increase the probability of development of cirrhosis? The answer is yes. It definitely increases. Fortunately, I think the last few years we have seen a trend of lesser number of Hep C positive in alcoholics as compared to what we used to see around 20 years ago. That's also because probably of the DAs. So I think it is becoming lesser of a problem. Hep B, though, still remains a major problem in alcoholics. So it is not just Hep C, but even Hep B is much more likely in patients with alcoholic liver disease as compared to general population. In fact, there's one study to show that almost 22% of patients with alcoholic liver disease can have coexisting hepatitis B infections. Data from AIMS, it's only. And therefore, I think everybody with alcoholic liver disease must be tested for hepatitis B and hepatitis C. I think that was the point which I had not included in my talk, but I think thank you for Dr. Banik for bringing this up. So every single patient with with any liver disease should be tested for hepatitis B and hepatitis C, because these are treatable. And if we don't treat, then they will definitely cause accelerated damage because of any other liver disease that is there, whether it is alcohol or it is NASH. Uh, Anybody has any final comments? I think 9:45 we intended to wind up, so we have 2 more minutes. So Ashok,
Sir, one about alcohol intake. If this patient recovered, he wants a social drink. Are you going to allow him?
so I think this is a very important question. What I personally tell my patient is, I have a very standard phrase that I give them two reasons. One is I ask them not to have alcohol ever again, because it is always the first drink which leads to the second, which leads to the third, and then it starts a domino, and then they cannot stop. And to convince my patient, I tell them that you're not allowed alcohol on any occasion also, whether it is birthday, marriage, parties, New Year, or Holi, Diwali. So no pretext, and no type of alcohol also, because many of them will consider that beer is not alcohol. Many of them will say wine is not alcohol, it is not bad for the liver. So we have to tell them very clearly that no alcohol in any form, no whiskey, no rum, no wine, no gin, no vodka, no beer, no tadi, no madi, no desi, videsi, narangi, संतरा. So किसी भी तरह की ड्रिंक किसी भी कारण से एक बूंद भी नहीं पीना है. So this is my standard dialogue, and what I write on paper is to stop alcohol completely and permanently. So this is what I do, and I know that if they're absolutely fine, they have recovered, they are non-cirrhotics, probably having once in a while would not cause any major liver issue. But I am always worried that it is the one drink which will lead to the second, which will lead to the third, and then it will again escalate, because that is the nature of the disease which we discussed. So it is important that we stop the first drink of recidivism. I think that is where our focus has to be. I think that is where Alcoholic Anonymous has been successful, because they give this option of coming and sharing the moment you have got of craving for the first time.
So last concluding I will take from Akash. Dr. Akash, how will prevent alcoholic liver disease? How in a routine practice you will guide your patients as a physician? We discussed about the treatment.
Hello, sir, is it audible?
Yeah,
Yeah,
audible.
I can hear you.
So the prevention of alcoholic liver disease, I think it's more a societal and it's more of a state policies and societal changes which needs to be brought about.
Okay, that means you want to you want to at the enforcement of alcohol intake.
Hazardous drinking awareness, increasing awareness, increasing the rules and regulations by the governments, individual governments,
No,
possibly those other.
no, that is one part. That is one part. Most important, what I want to expect that you should suggest is that alcohol with mixed. Someone takes some joyful things, smoking. Are they anything causing more aggravation of the injuries? One, two, a trio, diabetic, obese, and alcohol. This is a common fact we see. A person is जो हम बोलते हैं खाते पीते घर के बच्चे. That is a disease of aristocracy. He is a diabetic, he is obese, and take alcohol. So what are they should know, and at least in our clinic as a general physician, we should emphasize on these points. When you counsel for 5 times, they may be convinced in once. So these in this way that they should avoid any comorbid condition if they have alcohol, they have to know their limits. That is two. Then third is that they have a risk factors. And is there any relevance? Suppose in family, father has alcohol-related liver disease. Is genetic is going to do anything for the kids? They take alcohol. So these are things. If we can get some ideas, that will be more fruitful or in a preventive way.
Absolutely, sir. Absolutely. I think this should be a part of our practices on a daily basis, that whatever chances we get for any patient who may not be coming with an alcoholic liver disease, to make them aware of the harmfulness and the problems that they might land up with hazardous drinking.
And I think the point on concomitant substance abuse is important. So very often we get a question, doctor, can I smoke? So patients with alcoholic liver disease, they'll come and ask you whether they can smoke. So by itself, we know that smoking does not cause any liver damage, but it does prevent liver from recovering. We know that smoking causes impaired liver regeneration. So those who have a liver disease, their liver will not regenerate if they continue to smoke, if they continue to have tobacco. So therefore, it is extremely important that we emphasize on these patients not to have any tobacco, not to smoke, and not to have any of the other substances in any form. So they may not directly affect the liver, but they do hamper the recovery of the liver. One last point, Ashok, I think, which we didn't discuss today, is the role of rehab centers. I think that is again something which is sometimes I feel just a fashion. Sometimes it's an escape for the family that they just send the patient to rehab center. It is more out of frustration. They cannot do anything. So just send him there for 6 months or 1 year. I would want to ask Acharya sir again here. Sorry, sir, I'm bothering you again and again, but I think these are pearls of wisdom which we need from you. You tell us, sir, over a period of years, one, do you find that the rehab centers are any better? And two, do you think, at least in some patients, would it make a difference to the eventual outcome? Or they are probably just escape routes?
Any center that provides a holistic approach, starting from counseling, taking care of their health, and healthcare providing together, is a great thing. There is no doubt about it. The healthcare center conceptually should be built on these grounds, on helping those who are, you have defined medically, as alcoholics or are having alcoholic abuse with or without disease. They can be structured with disease, without disease. Who needs reform, who needs treatment with reforms. Now for that, you need a proper team here, not these ad hoc methods, right? You need a proper team of regular psychoanalysts, psychotherapists, nutritionists, regular health assessor, physiotherapist, right? Medical experts, right? It is a combination of things. If you want to provide benefit to them and turn them back into the society, it's a holistic approach. Now we are far from that. The first thing, therefore, awareness, step one, which is practical, that alcohol kills. Simple.
Yeah.
Before that, one message, if you can get through people, that alcohol kills. Your childhood days, alcohol was taboo in our village. Now I see it is not a taboo in my village. That has to be reversed. And that is the challenge. If you reverse that, you have prevented alcohol.
Yeah, sir. In fact, now it is considered a social outcast if you are not having alcohol. So
That's
the trend
it.
was so much. So
So,
people feel out of place.
Akash, you have, for public health purpose, you have to strike at the root.
Absolutely, sir.
In a tertiary care purpose, we can devise some treatment and we know where we are.
Yeah, absolutely, sir.
And that is why this is a very important thing to understand. The striking at the root, right, to yield results, if you want it. It's a very difficult thing, I understand. Having said that, I understand it's a challenge. And I don't think there is any will to do this. And neither political will, nor there is a social will, nor there is a revenue will, nor there is a medical will. Right? दारू पी के जो बंदे आते हैं, right? उनको कौन advise करता है? Who holds their hand? Nobody holds their hand. So there is a lot of problems. It is a structured approach. But you are right. You have put forward the points very well, which are well accepted worldwide, that they need a composite approach to get rid of alcohol, get rid of the liver disease, and have a qualitative as well as quantitative life. And the approaches we all have described. But these are very difficult, tricky questions in a disease which is behavioral disease. This is a behavioral disease.
It's a behavioral disease, absolutely.
That is a behavioral, it's a big variable itself.
Yes, in fact, sir, I usually classify my patients with alcoholism as pure alcoholism, which is a behavioral issue. And second is those who have got a personality disorder with alcoholism as one of its manifestation.
That's why it's an interesting thing. You have told about genetic factors and different mechanism, different manifestation.
Yeah. So I think we'll have to wind up now. I think 1.5 hours.
Yeah. Good.
Ashok, I think you can conclude the session.
Yeah.
And then we can have final comments from Acharya, sir.
No. I don't want to say anything.
Okay.
It's all right. Fine. You just conclude it. Right. But I think in alcoholics or controlling alcoholism or treating alcoholic liver disease, we have miles to go.
Yes, sir. But I think we have taken a few right steps. At least today, I think if the message of nutrition and abstinence, how to go about these two things, I think if
you have passed on a very important message. Liver जब जिगर खराब होता है, अच्छे तरह खाना खाना यार, स्वादिष्ट खाना खाना.
Yes.
ये important message.
Ashok, over to you.
Okay. Thanks, our speaker, panelist, and esteemed patron, Professor Acharya sir. So this is 5th we have concluded, and in the next month, 4th Friday, again we'll meet for the 6th session. And today we learned a lot of things, you can say, nutrition, risk, how to go for. So this is definitely going to help in our practice. And I request everyone to, those who have attended, please rewind the discussion section definitely. Excellent talk by Professor Shukla, who has delivered in a very lucid way what you can do. And third, we are coming to you with our newsletter on these topics, so you can read at your free time. So with this, we are going to close this session. We will see you again after 1 month, the same 4th Friday, 8:30 p.m. Thank you. Good night. Bye.
Good night. Thank you, Ashok. Good night.